This photo goes back to 2007 when Emory University implanted their first TAVR in the southeast of the US. I'll start by saying, structural heart centers cannot function without having a heart team consisting of surgeons, interventionalists, imagers, anesthesiologists, and that's kind of a standard expectation. And heart team priorities have shifted substantially over the past decade. The main focus used to be procedural success and mortality prevention. However, as the indication have expanded to include younger and low-risk surgical patients, our priorities have also expanded to look into durability of TAVR valves and how many prosthetic valves patients will need in their lifespan and what challenges they will be facing with putting more valves in valves. So where does TAVR stand today in 2024? We've proven safety and efficacy, and we've expanded indication to low-risk surgical patients. Where will TAVR stand in the near future? I think soon we will know whether we should be replacing valves for asymptomatic severe AS and moderate AS, and currently at Emory we are enrolling patients for what we call the Jena valve, which is a German valve that was bought by the Edwards for severe AI. But as we're doing more TAVRs, we're facing many challenges, including vascular access, coronary access, leaks around these valves. We're also trying to reduce strokes, and we're currently doing the Emboliner study at Emory to look into that. Durability of bioprosthetic valves remain a big challenge. And in the next few minutes, and given the time limit, I'll just talk about a few of the challenges we face when we plan for TAVR. Vascular access is the most common problem we face, especially in the elderly here in the US with heavily calcified vessels. At Emory, we manage this problem by two main ways. IVL, or intravascular lithotripsy, or shockwave, is the first thing we try to do. And the reason we try to do that is alternative access results in worse outcome, including mortality, vascular complication, bleeding, strokes. Also, alternative access adds more complexity to the case and requires a steep learning curve, and sometimes you have to transfer patients to other experienced centers. So IVL came some years ago as a game changer in transfemoral TAVR, and there's been multiple studies showing its effectiveness and safety. And since the emergence of IVL, transfemoral TAVR has increased significantly from 90% in 2016 to 97% in 2020. And this paper was published in Eurointervention based on the European registry, showing that about 6.5% of TAVR currently is IVL assisted. And I think these numbers are still consistent with what we're doing nowadays. The current generation of IVL is used in the US. It's called Shockwave. It's a catheter that goes over 014 wire. It has 6 emitters in the peripheral version, and we inflate the balloon to just 4 atmosphere pressures, and then we activate the emitters, which generate sonic pressure waves, and these waves form kind of a microfractures addressing the vessel calcium and increasing the vessel compliance. This CT is for an 85-year-old female, severe PAD and severe AS, who's referred for TAVR. She has severe PAD. Typically, you would want the vessel size to be, more than 5.5 to 6 based on the sheath. But as you see here, the vessel size is very small, so we decided to go with lithotripsy-assisted TAVR. This is the angiogram in the beginning. Then we went in with 7 French sheath and a Grand Slam wire and the shockwave balloon. And as you see here, the shockwave started to pulsing, and then the balloon yielded well at the end. And these are the rest of the 300 pulses that we delivered in the left iliofemoral system. And then we were able to go up with a 14 French Edward sheath and deploy the 23 Sapien valve. And this is the final picture with good result. Well, what if iliofemoral disease is severe enough that lithotripsy won't be an option? So our second step here at Emory, we do alternative access. We have the transcable access. Transcable access is a brilliant idea that was first invented or done at Emory University in 2014 with collaboration with the NIH. Simply, we take a catheter through the femoral vein, up to the IVC, then somewhere in the IVC, we cross to the arterial side and go up to the aortic valve and replace the valve. At the end, we close the aortocaval fistula with what we call a vascular plug, and it works beautifully. You know, the reason transcaval works is the physiology that seems to be counterintuitive. We all know that the interstitial pressure around the aorta and IVC is positive, and it's higher than the IVC pressure. That's why if you poke a hole in the aorta and a hole in the IVC next to each other, then instead of having catastrophic bleeding, the blood will go from the aorta to the IVC and decompress the aortic bleeding, and that's what makes transcaval access possible. CT planning for transcaval access is crucial, and as structural cardiologists, we study the CT and look for the best location where to cross from the IVC into the aorta. We have to pick a calcium-free zone in the aorta, be away from large branches such as the renals. Sometimes we jail the inferior mesenteric artery, and also we have to be at a reasonable distance from the iliacs and renals, where it would be safe to put in a covered stent in case of complication. There's a lot of technicality about this, but and we can talk about it in details in a different meeting. This is the baseline angiogram. We first take that, then we went in with a 7 French sheath in the IVC and a snare in the femoral artery. Once we are at the desired location, we connect the wire to an electrocautery, and then we burn through with an astato wire, and we push from the IVC to the aorta, and then we snare the wire, and then we go up to the aorta. Then we go up with the 035 stiff wire. We use Confida wire, Linderquist, Amplatz super stiff, any of those would work through the IVC into the aorta. Then it becomes a regular TAVR procedure. That's the Edward sheath going up. At the end, we close the aortocaval fistula with an occluder device, and this is what the final angiogram would look like from the aorta. Compared to transaxillary access, transcaval had significantly lower risk of stroke and shorter hospitalization, and we have proved efficacy and safety of this technique through the transcaval IDE trial, which was published in 2019 in JACC Intervention. And when it comes to ergonomics and radiation exposures, our interventional colleagues would know that layout of transcaval is similar to transfemoral. So unlike transcarotid and transaxillary, where you have to stand by the head and be exposed to a big amount of radiation. Next, we move to talking about coronary access. Coronary obstruction after TAVR is a devastating complication, and nearly 50% of patients die shortly after this complication. So it's not something we want to have. I'll start with a case, a 78-year-old male with biprosthetic mitral flow 21 millimeter valve and REMA to RCA in the past, now has severe aortic stenosis. What we need to know regarding the mitral flow valve is that it's externally mounted, and the height of the leaflet is 14 millimeter, and this increases the risk of coronary obstruction. So as a structuralist, we need to be familiar with the different types of surgical valves, whether it's mitral flow or Magna or Inspiris or Freestyle. And there is a good app that we use. It's called Valve in Valve that you should look into. Looking at the angiogram of this patient, I think we can all agree that the left main takeoff is very low compared to the biprosthetic valve. This is a nice paper published by the Emory team in JACC Intervention last year, explaining coronary obstruction prediction model. Bottom line is, if the cusp height, whether it's the biprosthetic cusp or a native cusp, if it's higher than the coronary height, then that's risky. And also, if the VTC or valve to coronary distance is less than 4 millimeter, that's unfavorable. Normally, TAVR is performed in a capacious aortic route where the blood would flow unrestricted around the valve into the coronaries. In patients with crowded sinus and low-laying coronary arteries, the coronary blood flow would be obstructed by the old biprosthetic valve or by heavily calcified native leaflets after TAVR. And that's why we came up with what we call Basilica. Basilica is a genius idea. Again, it was first done at Emory University in 2016 with the NIH and University of Washington. The concept of Basilica suggests that if a leaflet could cause coronary obstruction. Just as a single tear in that leaflet can create a gap. And that gap would allow the coronary blood flow to happen once we place a new valve in. There are different types of basilica, but we won't go into those details today. These are examples of sapien and evolute valves inside surgical valves, before and after basilica. And as you see the gap that was created by basilica here, this is the gap through which the blood would be flowing into the coronaries. Basilica IDE trial was published in 2019 in JACC Intervention, and it proved safety and efficacy. Going back to our patient, as you see in the CT here, the left leaflet here is way higher than the takeoff of the left main, and also the VTC is less than 4 millimeter, and also what we call the VTSTJ is less than 2 millimeter. And all of these confirm that this patient is at high risk of sinus sequestration and coronary obstruction. So we put in a guide. We use biplane when it comes to these types of procedures. So the biplane is really important. We put in a guide at the base of the leaflet from the aortic side, and then we put in a snare in the LV, and then we take a picture confirming our position, and then we go in with an astato wire, then we connect the end of the wire to an electrocautery, and we electrify the wire using a short burst of cutting radio frequency energy. And then we're able to traverse the leaflet scallop into the LV. Now we have a wire going across the base of the leaflet. We're able to externalize the wire by trapping it, snaring it, and then we are able to invaginate it and externalize it. And then we do what we call a V, or a flying V shape. It's a very nice technique where we use the blade and scrape the wire to remove the insulator material from the wire. Then we bend the wire to make a V shape, and then this V shape would be going in again to the body and would help us lacerate that leaflet. This is how we electrify wires. We connect it to an electrocautery, and we use the cutting feature of the electrocautery. We typically use 50 to 70 watts. The scallop is then lacerated by applying the radio frequency energy, and we pull on both guides, and then we lacerate the leaflet. Then we proceed with TAVR quickly because we're going to have a lot of AI at that time. Final angiogram shows great blood flow to the left coronary system. In this case, we did not need to worry about the RCA because it was bypassed already, but in some cases we do double basilica, what we call doppio basilica. Some final thoughts as we start doing TAVRs in Yemen. We need to remind ourselves that any prosthetic valve is a disease by itself, and that includes TAVR or any transcatheter valve. So we need to understand how to manage that disease long term. Patients also need to know the limitations of these valves when they consent for these procedures, how long these valves would last, and what would happen if they need valve in the future. And in addition to that, I cannot stress enough how important multimodality imaging is important in the structural field, and how important a structural cardiologist need to understand reading and analyzing cardiac CT and echo, including 3D echo and TEE. And at the end, we face many challenges in structural cardiology, but we have many solutions. Some of these solutions that we do here at Emory: transcatheter electrosurgery, transmitral, transpulmonic, transaortic, and tricuspid valve replacement. We also do perivalvular leak closure with the Totsi roll technique. We also do bassinet for ventricular septal rupture after MI. We also cut leaflets with lampoon and shortcut, and we also remove leaflets with cathedral and unicorn. We are also remodeling myocardium with HOCM. What we do sesame technique, and we're also cutting mitral clips in some cases with the ElastaClip technique. These are some of the techniques that we use here at Emory, and trust me when I say the future of structural cardiology is bright. This is our structural cardiology team with the pioneers, Adam Greenbaum, Vasilis, WR is going out for lunch. We recently celebrated our 5,000 TAVRs at Emory University. And finally, I would like to thank you. Thanks